against the translucent membrane. What is this called? Yes, phytopapricious. You're right, physician, Dr. Kam. Phytopapricious. How I wish I got a picture that time, but I think I didn't have a phone. I used to use the Nokia 3310. It had no camera. So, that is one option. Now, the other thing you need to look at is the active management. So, if you don't want to go by that conservative approach, you can do active. So, what we normally do is use mifepristone. I don't want to talk about the pharmacodynamics and kinetics of this drug. It's an interesting drug. Mifepristone. So, you normally use 200 milligrams. PO starts. So, you give it like today, mifepristone alone. Then the following day, after 24 hours, others say 24 to 48 hours, it's up to you. After this, then you now insert misoprostol. So it's up to you. Maybe you can use maybe 400, depending on the gestational age, to 600 microgram per vaginal, maybe 6 hourly, I don't know, whatever. Then once you think that now the cervix has ripened, the whole reason for mifepristone is to ripen the cervix. But the misoprostol is better for cervical dilation. Then you can proceed with MVA. So this is how those people who terminate pregnancies normally do. Me, I was one of them. It was my teacher. I always mention her, Miss Gracilia Mukomba, retired gynecologist. She told me, you will never terminate pregnancies. And when she gives instructions, me, I had to follow, even in my practice. So that is basically the principle. So you find that there are some patients who come, because some of these miscarriages we deal with have been induced by some people. If somebody has used misoprostol, then they come and claim, say, no, me, I just found the bleeding started on its own, I'm even surprised. I'm pregnant, doctor, me. If somebody has used misoprostol, there's a way in which the cervix changes, which can show that this was pure misoprostol. If they've used the combination of these two, again, there are changes that you see on the cervix. This becomes almost a simulation of normal labor process in terms of cervical effacement and dilatation. But if people use misoprostol alone, it will try to dilate, but then there will be no ripening. And no wonder most of them will come as incomplete. Because in that way, not everything will come out. And unfortunately, some of our fellow clinicians in the community, there are also clinicians, they don't just have uniforms. They even tell the patient to say, no, it's normal to bleed for the next 1 month. These are hot periods. I want to come with a very septic. Doctors in Campo, I don't know that they even have titles. They're also called doctors. Yes. So last one. I'm on the last one? Yes, it's good I'm finishing. I'm very, very happy I'm done. The last one is recurrent miscarriage, number 7. Very quickly. Like I said, this could be a topic on its own, but I'll be very brief. So in terms of what I can say, classification. It can be congenital or acquired, because we are basically saying the pathogenesis of this condition is weakness in the cervix, particularly the internal cervical os. The weakness is at the level of the internal os, not the external os. Now, congenital causes of this could be Mullerian problems. Remember, the paramesonephric ducts are what forms the upper two thirds of the uterus, and the upper part of the vagina there, and then the urogenital sinus. Remember the genital tuber, and all those the vaginal bulbs. That's again, the embryology of the uterus. So if it didn't form well, you find that the cervix becomes deformed, and you end up with this. The other one could be that somebody has got collagen disorders. Like for instance, the Ehlers-Danlos syndrome. Again, we have physicians in here who can explain better the diagnosis of Ehlers-Danlos. Then we can also have a congenitally short cervix, and so on and so forth. So these are congenital causes of recurrent or whatever. Then acquired, we think of cervical tears. You know, whenever you have a cervical tear, it's not tear, it's tear. Cervical tear, and you don't repair it properly, or you don't even repair it. There's weakness. What else? Excessive dilatation during a process called D&C. So using big rigorous dilators during D&C, it will permanently open the cervix. Then also cervical cancer procedures. What do we mean? Lip. When you are doing a lip, we know it's like a conization kind of, or even bone biopsy itself, which is using a cold knife. Can you be disposed to cervical incompetence? So always think of this. Now, in terms of symptoms and signs, there are 3 things that you need to think of that will make you think this could be cervical incompetence. Number 1 is the spontaneous. Number 2, second trimester, meaning between 3rd to 6th month. Loss. This one, again, you find that it is recurrent, but even if it's recurrent, it keeps worsening with the gestational age. What I mean is, the first loss was at 6 months, the next loss will be at 5 months, because the weakness will be progressive. The next one will be at 4 months. So that type of a history. And finally, they are usually painless expulsions. Very traumatizing. I've seen with my own 2 eyes a woman saying, I was actually in class teaching. I'm a teacher and I just found the gestational sac comes out. So, because it's a structural problem, you find that there will be signs of life. Unlike those other causes, which goes for the fetus. But this one, it's just that the fetus was okay, but it just had the cervix that can't hold. So you now asking a patient to say, when the expulsion happened, was the baby smiling? That is academic indiscipline. How can you ask such a question? So some of these questions, don't even ask. It's not necessary. Investigations. I think I already talked about it to say we need a transvaginal ultrasound scan, not an abdominal. An abdominal is not good at assessing the cervix. So, what did we look for on transvaginal ultrasound? We are looking for the cervical length, meaning this length here from the external os to the internal os. This length should be more than 2 centimeters. That's the normal. So if it's less than 2 centimeters, be suspicious. 1 centimeter? What? Yes, vaginal you can try to check, but the vaginal one will only check the ectocervix. It will not check the endocervix. So no wonder a scan is better. Number 2 is for cervical internal os patency. How closed is the internal os? So I was explaining in the last major round to say the normal is this picture. It should be 90 degrees between the uterine cavity and the cervix. Not a picture like this. There should be no funneling. Funneling is a sign that you might end up with cervical incompetence. And I gave a lecture on preterm labor and the role of fetal fibronectin, which is important in predicting some of these events. Treatment. Treatment is obviously cervical sacrilege. So we put a stitch around the cervix. When do you do this cervical sacrilege? We normally do it between 14 to 16 weeks. If you do it after this, going this way, it's called an emergency sacrilege, or it has another name. It's called a rescue sacrilege. Now, the fear of doing a sacrilege after 16 weeks is that the membranes have come close. Because remember the funneling there? So the amniotic sac will even follow the funnel, meaning it has even gone below the level of the internal os. So when you are putting a cervical sacrilege, you also have to aim for the internal os. So chances that you can end up iatrogenically puncturing the amniotic membrane is very high. Now imagine a patient goes to theater only to come licking with the liquor. They'll be very upset with you. So again, if you say, no, I'm too careful, I don't want to go to the internal os, just that procedure of doing it closer to the external os will even make the process of expulsion happen on its own. 1 hour after the sacrilege, patient goes in PKM. So you have to be careful. So what we normally do for such operations, we put the patient head down, like the way we operated last time. Do you remember?
Yeah.
Yes, where we put the head down and the trunk up. Yes, so that the membranes go backwards, and then anyway, it will be a discussion for another day. Now, the methods of doing cervical sacrilege are two. We have an old one, which was called the Schroeder approach. So in Schroeder, what was happening is that you, like the way you do a subcuticular stitch, you bury the stitch within, because you are in lithotomy, and you put the speculum. So you put the stitch around the external os and it's buried. Now we no longer do the Schroeder, but we've gone for the McDonald's. Again, when I say McDonald's, some of you even feel hungry. It's not like McDonald's restaurant, no. This is an academic McDonald's. So in this one, it's a pastry. I don't know how many of you have observed this procedure of cervical sacrilege. We just put a stitch around the cervix. So you just go, this is the cervix, you put a stitch, and then tie. It's as simple as that. But you need to know at which point you are going to be getting the bites, because you need to know the direction of the branches of the blood vessels. Now, what do we use? We use what is called a Messelin tape. These markers are disappointing. Messelin tape. So it's a tape. It's not really a suture, but it's a tape. It's a strong thing, which you use. Now, most people, the problem they make is that when they put the cervical sacrilege, they cut the knot very short. So as the pregnancy grows, the knot will disappear and get buried inside the cervix. Very difficult to remove. So there's a way in which, personally I learned from another person, when they tie, then they create a window and tie again. So they create a hook, which will be used at removal. So when you're removing, you pull. Because removal is not in theater. Removal is in labor ward. You just get an instrument and cut the way you remove stitches on the ward, and then you pull one side. When is the removal supposed to be done? It is done at 38 weeks. At 38 what? Weeks gestation. Except in 4 conditions when it can be removed before. What are those 4 conditions? Number 1, preterm labor. Very dangerous. If labor starts with a cervical sacrilege in situ and the cervix attempts to dilate, what will happen? It will amputate the cervix. To cut it into parts like that. So that is one fear that we have. Number 2, when there's IUFD, obviously. Number 3, when there's draining. And number 4, when there's bleeding. We might remove that sacrilege earlier. Okay. Of course, at postgraduate level, we can argue those reasons. Some of them will be knocked off based on evidence. But let's just know that generally those are our guiding principles. I'm done with the 7. Can I conclude with one last component? Small one, 5 minutes. It's called post-abortal care. Post-abortal care. So, do you know that there's even a way in which you can put the cervical sacrilege abdominally? So you can read about that. Especially for a very, very short cervix. You cannot approach it vaginally, we can approach it abdominally. I've seen that procedure before being done. Yeah, so you enter into the crypto. Anyway, I don't want to talk about the space of resilience. I said it's a topic on its own, but I think I've tried to peruse through. Now, let's go to the post-abortal care. Why is post-abortal care important? It's because, like I said, patient came bleeding, came in with intermittent abdominal pain, backache. They are ill. So you've done the MVA, everything nicely, and the patient is about to go home. Right? Do you think they are still happy? They are not happy because they've lost a precious baby. So you need to have that component of counseling that I was talking about. So it's called post-abortal counseling or care. So principle number 1 in post-abortal counseling care is explain possible cause of the miscarriage. That list I gave, you try to use it, but in simple language. Mommy, sorry, mostly when you lose a pregnancy, we didn't all expect this, but it's mostly because the baby did not form well. The baby forms in the first 3 months, where some things join, disjoin, however, if anything goes wrong, the body knows and it rejects that pregnancy. So meaning that baby was not even forming well. In fact, it wasn't even a baby yet. You see, you give explanation about blood group, about sugar, about this. Number 2, you need to give counseling on compliance to antibiotics. This is a patient you prescribe some antibiotics. What will happen? She's feeling well. She won't even take them. Me, I've been healed. But what will happen? They will run the risk of pelvic abscess, bilateral tubal blockage, and hence infertility. They will end up with all kinds of complications, including chronic pelvic pain, and the rest is known. So you tell them to say, please finish your 5 days of antibiotics. Number 3 is tell them about the danger signs. Tell them that now you are not bleeding, but should you go to the home there and find that bleeding comes back, you have a fever, you have a discharge, you have pain, even before the 1 week review, come back. Because it could be that some few things remain. The 4th thing is family planning. Because when you have an MVA done, what the body takes is as if it's a period. It's now preparing for the next cycle. So if this woman is still psychologically affected and uses no form of contraception, she will again get pregnant before the anemia is corrected, before she's psychologically ready, and that's not good. And then the last is to prepare for preconception care, like I mentioned. Get contacts. Maybe, Dr. Sinkamba, we need to have a register of high-risk mothers, or sickness being seen in pediatrics, or diabetic girls who are on insulin. At some point they will grow, at some point they will get married, at some point they will want to have a child. The question is, who makes that transition between pediatrics, then internal medicine, then obstetrics? So we need to speak the same language, and you have to give us those clients. Don't hold on to them. You people are doing pediatrics. Because I've seen that some patients, and as I conclude, becomes attached to their doctors. Somebody is 20 years and they still go to pediatrics. Because this has been my doctor from childhood. They are like an uncle or an aunt. So you need to transition them so that they have preconception care. Now, having said that, and we've concluded, I will not talk about the post or what is called the Abortion Termination of Pregnancy Act, because my teacher does not allow me. I will mention Ms. Nkumba should be upset. I rest my case.